Hey, what's up, guys? Gary Gratz, and this is going to be part two for some paramedic questions, just to kind of help you guys get ready. So let's get started. All right, what is the best place to check a pulse on a newborn? Well, there's a couple good answers here. You got like C and D, the carotid pulse and the femoral pulse. So we've got some central pulses. Those are always pretty good places, no matter who. And but I would say the two juicy answers here are the umbilical cord or the brachial. If you don't know, when a newborn first comes out and they are still attached to the placenta, and it's still pulsating, you can put your fingers down at the base where the umbilical cord essentially connects to the newborn, and that's a pretty good place to check a pulse. The only problem with that is as time goes on, the pulse becomes weaker and more irregular. So believe it or not, the umbilical cord becomes pretty unreliable pretty fast. So your still number one go-to is going to be the brachial. A 67-year-old with hypotension or bradycardia has not responded to pacing or atropine. You should administer what? All right, so you tried pacing, didn't work, gave atropine, didn't work. So what drug are we going to give? So if you're treating hypotension, if you really think about it, there's two ways to attack this. Number one is you could try a push dose pressor, but that's a short-term fix. You really do need to give essentially a pressor agent. So let's see what we got. And by pressor agent, I mean a drip. You need a long-term drip, a per minute drip, I should say. So let's see. In epinephrine infusion, that's good at 5 to 20 micrograms a minute. Not quite the right dose. Be careful of that because that's a pretty juicy answer. 40 units of vasopressin. Wow, we haven't given vasopressin in quite pre-hospitally anyways in quite some time. That if you're unfamiliar, that was one of our go-tos for cardiac arrest. We used to be able to choose between a 1 to 10,000 epinephrine code epi, or you could give 40 units of vasopressin, but only once, and it could either be your first or second dose. C, a dopamine infusion. You can do that at 2 to 20 micrograms per kilogram per minute. That's a good dose. Or D, 1 milligram of epi via IV infusion. No, that's if they're dead. So A and C are your best answers, but unfortunately A is the wrong dose. So C is going to be your guy. All right, let's check it out. A 19-year-old male has suffered blunt trauma to his chest. He complains of severe dyspnea and pain over the affected area. I think we know where this is going. Vital signs are blood pressure of 92/60. So you're starting to see signs of hypotension plus tachycardia with a pulse of 128. Okay, and respiratory is 32. Breath sounds are diminished over the left side. It's a no-brainer. Trauma to the chest, diminished lung sounds, hypotension. I mean, it's a this individual needs to be decompressed. It's a no-brainer. So pericardial centesis, nope. That's for pericardial effusion. Or I should say fluid in the pericardial sac, right? Initiates 2 large bore IVs with normal saline. Nope, he can't breathe. Perform a needle thoracostomy. That's your guy. Or perform endotracheal intubation. No, you have to decompress this guy. And perform needle thoracostomy is just another way of saying decompression. All right, a 4-year-old pulls a dresser down on top of himself. The patient shows a laceration on his forehead and a bruise on his chest. Okay. The vital signs are blood pressure 140/90. That's interesting. So he's a little hypertensive, a 4-year-old. Okay. Heart rate of 70 and hypertensive. Respiratory rate of 36. So that's, I mean, that's not abnormal. What would be your primary concern? This is interesting because if you look at this and so you have a traumatic child, right? And they tell you there's an injury to the head and an injury to the chest. Okay, so we're either going to be looking at some type of intracranial pressure, or we're going to be looking at cardiac contusions or pneumothorax or something like that, right? Pericardial tamponade or something like that, right? So what clues do they give you to answer this? Well, the vital signs is really all they're giving you, besides the 2 physical injuries. But he's hypertensive and bradycardic. And I know it's easy to look at this and go, 70's not bradycardic. Well, he's 4 and he dropped a dresser on himself. So I'd say that's not very fast. And then, of course, his respiratory rate's a little high. So if you were going to go with chest injuries, very unlikely you would get hypertension with any of them. Any chest injury, it's unlikely, unless maybe you damage the spine, right? If you damage the spine somewhere in the T4 to T6 area, you could interrupt the sympathetic nervous system and you could cause some hypertension in that case. But there's no indication of any of that. Here, this screams ICP. It really does. Hypertension, bradycardia, and the respiratory is really irrelevant. But yeah, this definitely this looks like Cushing's triad more than anything. So there you go, ICP. 44-year-old patient has a persistent cough. Okay, occasionally spits up blood. Okay, without reading another word, if they're spitting up blood, they usually get at 2 things. If they're spitting up blood, the number one thing that goes to my mind is tuberculosis. But it could be other. You could have GI issues. You could have Mallory-Weiss tears, or esophageal reflux, or whatever. Esophageal varices or something like that. But let's keep reading. Spits up blood, sputum, has been living in a shelter for 3 weeks. Okay, so there you go. It's tuberculosis. 3 weeks, also smells like alcohol. Okay, whatever. The alcohol thing could, possibly they could want to try and hint towards pushing you towards, liver, varices, maybe something like that. But that's not this question at all. This question gives you somebody who lives in a homeless shelter and spitting up blood. It's tuberculosis. So what are you going to do about it? Put an N95 mask on and eye protection. That fits. Suction. No, it doesn't give you any indication for that. Administer O2 via non-rebreather, which is not a horrible answer. They give you no information to go with that. There's no respiratory component here. Apply ECGs and check the blood glucose. Things that you would do, but it's obviously number one, first and foremost, is always protect yourself. So that's a freebie, that's a freebie. 2-year-old male has been sick over the last 48 hours with a low-grade fever. Okay, low-grade fever is a clue. and has been sick over the last 48 hours. That is also a clue. Runny nose, upper respiratory infection. Okay, so they tell you straight up, kid's been sick with an upper respiratory infection. Low grade fever, which sounds viral, over 48 hours, also sounds viral. Has a seal bark cough. That sounds like croup, which is also viral. The patient is using accessory muscles to breathe and appears fatigued. Okay, so he's progressed and he's in the realm of respiratory failure. The upper airway has stridorous sounds, croup. His lungs appear clear. SpO2 is 92%. No big deal. How should you treat this patient? Right. Let's look. So A, nebulizer, nebulized albuterol. Okay, that is something that you can do. That is something that you can do for croup. Obviously, that is more of a lower airway medication. Let's see what else we got. Oxygen. Obviously, he needs it. He's in a level of respiratory failure. Nebulized epi, also known as racemic epi in transport. That's a great one, which is a perfect treatment for croup. Humidified oxygen. That is a good one for croup as well. Alternate between placing the patient in a humidified room and then cold air from the outside. Not something that you're typically going to see in medic books. I can tell you that that's not a terrible treatment. It's really not. But I'm not gonna. I'm a pretty big fan of using cool air in these types of situations. I've personally had pretty decent success with it because it does cause vasoconstriction, but it's by far not your best answer. Your best answer here is racemic epi, nebulized epinephrine. If you guys are unfamiliar with racemic epi, it's super easy to make. And it's funny thing about racemic epi too is it's not what you think. Like for example, like let's say you had somebody who had an allergic reaction, right? And maybe they had some wheezing and maybe some stridor with it, and you were like, wow, cool, well, I can do both. Even if you were like, well, I have 2 or more body systems and I have some upper respiratory involvement, which is definition of anaphylaxis, right? Wouldn't it be better to give epi if I know that epi goes straight to the upper airway? And the truth is no. The nebulized epinephrine is, believe it or not, when you add, sorry about that, when you add normal saline to epi and then nebulize it, believe it or not, you actually you change the isomers in it, which focuses that medication on the upper airway and not the rest. So thinking that, well, I could give racemic epi to an allergic reaction, thinking that I'm going to get a system-wide antihistamine effect, or not. So, but I will tell you that racemic epi is fantastic for croup. So oxygen, nebulized epi, and transport is definitely your best answer. And just in case, if you ever wanted to know, you guys can make it yourself. It's literally all you do is you take, if you think about most nebulizers, they usually base it off of 3 mLs of treatment. So it's exactly that. Take a 1 to 1,000, half an ml of your 1 to 1,000 epi, add that to 2.5 mLs of normal saline, boom, and you have racemic epi. It's great. If you don't want to draw up half, it's no big deal. Just all you got to do is take, you can take the whole vial, you can take the whole 1 ml of 1 to 1,000 and just add it to 5, and then you get a double dose ready to go. So a 48-year-old patient is choking on a hot dog. Okay, he's unresponsive. So we think about, I mean, right there, just think about it. So you have somebody who's choking, you start out with a Heimlich until they go unresponsive, and then what do? essentially we go into CPR, a type of CPR, right? Except we're going to inspect the airway and try and remove it. But he is unresponsive and has a strong pulse. That's good. Chest compressions are ineffective. Okay, timeline. So you've moved past chest compressions. They are ineffective at retrieving the obstruction. So without even looking at my answers, I know the next thing that I got to do here is either add oxygen to this mix or I got to physically try to remove it without any type of blind finger sweeping. So A says perform chest thrusts, which we just kind of did. Blind fit, nope, I'm out. Anytime you see blind finger sweep, yeah, I'm out. Use laryngoscope and Miguel forceps to remove the object, absolutely. Force the object out of the way as you pass an ET tube. That's a good answer. We're just not there yet. Place the patient into a recovery position and no, they're not unless you want to transport a corpse. It's got to be B. C is not bad. C is not bad. Because remember, if you think about it, if B fails, what if B fails? What are you going to do? So you honestly you have two options. The patient goes unresponsive. You lay them down. You try to ventilate them. You should try to ventilate them. And but if there is a true obstruction and you can't ventilate, you're going to do your chest thrust, see if you can knock it free. Honestly, guys, the best analogy I was ever given for this scenario was you think about like a 2-liter bottle. What if you took a 2-liter bottle and you put a cork in it? Think of the cork as the obstruction, right? And then you squeeze the bottle, but you squeeze it lightly and you slip a little bit of air past the obstruction, right? A little at a time, little at a time. Well, eventually there's not going to be any air left in the bottle to be able to pop that cork out. So being aggressive when you do this, getting a good firm thrust or compression to get that cork out is really, really important. So you got to get that thing out of there. If you are unsuccessful, get your blade and your Miguel forceps, get in there and get that thing out. Okay? Brain damage, remember, brain damage starts in 4 minutes. You do not have a lot of time. Okay? But if that fails, I mean, if it goes subglottic, what are you going to do? If you can't reach it with the Miguels, what are you going to do? Well, you have two options. Number one, you could try to get the ET tube passed, or you could crike them. And I was advised, and I've asked a few doctors about this, and I was advised that, hey, look, the true formula for criking somebody, when it's time to crike, you have to be able to tell yourself, I can't ventilate and I can't intubate, then it's time. Okay? And this is just as true. If you cannot get that ET tube past that obstruction into the lungs, you crike them. And I know I've said the same thing to myself, like, well, what if I push it beyond the point of the cricothyroid membrane? Sometimes there's just not good answers. So, but that's the way it's got to be. You got to either get it past that obstruction or push it into the right main stem, but you got to be aggressive in this situation. So long story short, B. You have just administered adenosine to a 62-year-old patient with narrow complex tachycardia. Okay. Adenosine, so it's got to be SVT. The ECG shows an irregular rate. Okay. An irregular rate of 90, then steadily climbs back to 180. So it looks like your adenosine worked for a second. Then steadily climbs up back to a rate of 180. What should you suspect? Sinus tachycardia with an aberrancy? No, because it doesn't fit the definition. You went greater than 180. You went greater than 150, I should say. It doesn't fit the definition. A rhythm of ventricular origin? Can't be. It's a narrow complex. Um, okay, PSVT. If you're unfamiliar with PSVT, that stands for proximal SVT. Proximal means it comes and goes. Um, but it comes and goes on its own. It doesn't come and go because you gave it a drug. And that doesn't dictate irregularity either, even though it does, but it doesn't. So if I had fast, regular SVT, and then regular sinus tach, regular SVT, obviously the rate is changing, giving it a look of irregularity, but that's not what they mean. PSVT is SVT in its core is what you call nodal reentry tachycardia, and it just keeps getting interrupted. And mainly, nodal reentry tachycardia is caused by uh, an extra beat. It's caused by ectopy, and it kind of self-corrects, and then it takes off again. And it just happens in that AV node, that fast and slow circuit. They just get interrupted, and then with PSVT, they end up fixing themselves and then go back. Um, But anyways, that's not what this is saying. It's saying you gave it a drug, it slowed down for a sec, you saw irregularity, and then it went back up to 180. That's AFib all day long. Ah, yeah, the Lund-Browder chart. So what is the Lund-Browder chart used for? This is a factual question. You either know it or you don't. Lund-Browder is it's a chart for burns. So if you're unfamiliar with the Lund-Browder chart, if you've never seen it, it's kind of like where your rule of nines kind of came from. But this is a chart that you literally you go through your patient, head to toe, and you look to see where the burns are. You go, okay, well, this part is burned, this amount is burned, and then you just record it on your chart, and then you can add it all up and get a true total body surface area and degrees. So the Lund-Browder chart is actually pretty great. Not even just for testing purposes, um, for clinical purposes. It's pretty nice to have. Okay, guys, last one. Looks like we got an EKG here. What treatment might be best suited for a patient with this ECG? All right, well, you got some pretty small P waves. QRSs are also not very big, but they are narrow, and then you have some distinct T waves. So obviously, looking at that, you have your typical peak T waves, right? It's an indication for hyperkalemia. There's no other way to get around it. Usually when you see this, it's either for a true potassium problem, or they have some level of acidosis, and those hydrogen ions end up pushing around the potassium, get their way in there. The hydrogen ions end up getting their way into the cell, end up pushing that potassium out, and boom, there you have it. You end up with a serum hyper K, and then you get some EKG changes. So what are you going to do about it? Lidocaine. Oh no, no way. Even if this progressed into what they call the ventricular sine wave. So if you leave this alone, eventually the T waves, they become pretty symmetric. They start pulling on the QRS, and you actually see the QRS start to widen, and then it turns into a kind of looking VTAC, really. And technically, it is a VTAC. It's an electrolyte-based VTAC. But when this turns into the sine wave is usually a lot wider than your typical VTAC and slower. It's like an odd slow. It's like 110 beats a minute. 110, 120 is an odd slow. And the other thing is that it's pretty big. It's like usually by definition, a ventricular sine wave is greater than 180 milliseconds. 180, 200, it's very wide and it's very slow. And if you were to give a sodium channel blocker like lidocaine, you can lock them into a repolarized state, and nighty-night, that's it. You're not getting them back. B, bicarb and calcium, it's a fantastic answer. That's your guy, without a doubt. Bicarb, in case it is acidic, you can clear it up and allow the potassium to return to normal, and then calcium will stabilize that cellular membrane. And it's actually pretty remarkable. If you do ever get to give calcium for a ventricular sine wave, um, it's actually pretty remarkable. You'll see it change right in front of your face. That's the thing about electrolytes. You don't see them listed with onsets because they're immediate. Electrolytes are an immediate action. Mag sulfate, nope. Mag, you're looking for more of a torsades if you're going to be given mag, or a VTAC. Honestly, a VTAC that you can't solve, you don't know why it's not converting. Consider giving mag in that case, but that's not this. And then Romazicon, yeah, Romazicon is also known as flumetazole, which is for benzodiazepine overdoses, not this. Um, so that's going to be your guy, is B, for sure. I actually think it's a bit aggressive. I don't think I would give calcium to this, but possibly bicarb, see what happens. I usually don't start busting out calcium until I start seeing a widened QRS complex. But that's just me. That's just my personal look at it. But the other answers are just straight up wrong. So, and it's kind of a good thing to think about, guys, when you're answering these types of questions. Also consider being deductive. Like if you're not sure, go through your answers. A lot of times, even if they like throw a drug at you, or you're like, I have no idea what this is, but you have an indication of kind of what's going on in the question, go through your answers and be like, whoa, that's crazy. Whoa, that's crazy. Even if it gets you down to 2 answers, at least you've got 2 to consider. But a lot of times being deductive will get you down to 1. So it's just another way to look at it. So that's it, guys. Thanks. That's the second set. Stay tuned. We'll get a third up here, up and running. And it's like I said, we'll also do some. I'm going to dive into some respiratory and cardiac mini lectures too. So thanks, guys.